uh, very important, and especially over the past 10, 15 years, we have advanced in the treatment of valvular heart disease using non-surgical or percutaneous technique, which I will mention uh, during my presentation. Uh, So heart murmur, when you have patient who comes with a heart murmur, you obviously need to evaluate it. A lot of heart murmurs can be benign or can signify mild valvular heart disease. But whenever you hear any type of murmur, you should really uh, be careful and evaluate patient. And sometimes we have patients who had murmur for 15, 20 years, and they have never been evaluated, or they were told it's fine, you have just a little murmur, and then they come with a severe valvular disease, and they need, basically they need intervention in a few weeks or months. So whenever you hear heart murmur, which can be, systolic, diastolic, uh, most of the time the heart murmur, when it's at the older age, over the age of 50, most of the time it's pathological, but there is a lot of benign heart murmurs, usually caused by increased flow through the ventricles. Um, Diastolic heart murmurs are most of the time pathological and signify some type of valvular disease. The most common imaging modality is the echocardiography to evaluate, the valves. And there are we use different modalities during the echo. One is a 2D imaging, which is I'll show you in the next slide. Imaging of the chambers. I think I showed yesterday physiological cardiac cycle by the 2D echocardiogram, and then the Doppler imaging, which is important to quantify Doppler imaging and color flow Doppler to quantify the severity of the valvular heart disease. And we use different measurements, different algorithms uh, to come with the final diagnosis. Uh, and again, the main issue is to first, to rule out severe disease that would require some intervention, and then to quantify mild to moderate, moderate to severe uh, disease. So this is just still picture of the uh, four-chamber view of the heart when we use the echocardiogram probe from the apex, from the below the breast, to the imaging. It's two-dimensional view. We also have 3D echocardiogram now, but still 80% of studies are done using 2D imaging. Left ventricle, the smaller, the probe is here, uh, close to the left ventricle apex. Left ventricle, smaller right ventricle. This is the left atrium, right? Mitral valve, which is closed. This is the right atrium. And uh, here you don't see the valve that well, but this is the tricuspid valve. It's a little bit more superior compared to the mitral valve. All right, so we'll talk about we have four main valves in the heart: aortic, mitral, which are the left-sided, and the right-sided valves are tricuspid and pulmonic. And again, the main concern is regarding the left-sided valves, especially the most common aortic stenosis and mitral regurgitation. I am not saying that the tricuspid and pulmonary valves are less important, but patients tolerate valvular heart disease on the right-sided valves a little more when it's moderate or when it's severe. Aortic stenosis, the most common stenotic lesion, especially in the older population. Now, with the advanced age, we see more and more patients with aortic stenosis. Can be congenital. Congenital is usually caused by malformation. The most common is bicuspid valve, but we sometimes see patients who have unicuspid. They have only one cusp with little opening uh, that doesn't always open completely, but unicuspid valve or quadricuspid valve. And the most common acquired is the degeneration of the valve with advanced age. There's also rheumatic heart disease may affect the valve. It can cause usually combined lesions, aortic stenosis, and regurgitation. And then less likely, Paget's disease. End-stage renal failure can cause some calcification of the valve. Usually doesn't cause severe disease, but it's probably in patients who have like end-stage renal disease, if they have severe aortic stenosis, it's usually a combination of calcification and degenerative disease with advanced age. And this is a pathological um, sample of the tricuspid, I mean the aortic valve. You can see three cusps of the aortic valve, and they are thickened, calcified, and there is only a little opening here. These are three different types of bicuspid aortic valve, uh, which you can see, and this is how we see it on the echocardiogram. Uh, there is opening, there is one cusp here, and then the other two cusps has, it's called raphe, which is basically they are connected, uh, and there is no there is no opening in terms of separation of all three cusps. So this is the raphe, and it can affect uh, either left or non-coronary cusp. This one, which is the most common, uh, the non-coronary cusp and right coronary cusp, or uh, this is the least common. We usually don't see it, but there is that typical only like two cusps, and there is no raphe. So we don't usually see this type of bicuspid valve morphology. What is this valve? What do you think it's this type of valve? Aortic congenital abnormality. Unicuspid, bicuspid, tricuspid, quadricuspid. Four, right? One, two, three, four leaflets of the aortic valve. So it's quadricuspid aortic valve. And this is the bicuspid valve. There is one cusp. This is the right coronary cusp based on anatomy. This is the non-coronary and left coronary cusp with the raphe that doesn't allow a separation of these two cusps. So what happens with aortic stenosis pathophysiologically? When when the valve doesn't open as well, it creates obstruction, right? There's obstruction, uh, which causes increased or elevated left ventricular systolic pressure. And in the very severe aortic stenosis, the aortic pressure decreases because there is a uh, decreased cardiac output, decreased stroke volume, which causes lower aortic pressure. So there is basically, we talked about it yesterday, increased preload. So increased systolic pressure leads to left ventricular hypertrophy, which is increased thickness of the muscle, and it can be mild, moderate, or severe. And it can lead to myocardial ischemia, myocardial dysfunction, and in very late stages, uh, patients can develop left ventricular systolic dysfunction, the ejection fraction drops, and untreated aortic stenosis leads to uh, left ventricular heart failure or systolic congestive heart failure. Now, pressure volume loop. Uh, were you there all of the, or are these two groups, or were you there yesterday when Dr. Michael discussed the pressure volume loops in valve diseases at the end of the lecture? No? All right. So we'll talk about it. So this is the typical pressure volume loop for aortic stenosis. Uh, this is the normal pressure volume loop. I will again explain it because it's not easy to remember. Um, this point should be point A, which is start of what? Ventricular filling, right? Ventricular filling, ventricular relaxation starts here at the end of systole when they will get there. So ventricular filling, um, there is increased volume in the left ventricle because of the filling from the atria. At the end, there is an atrial contraction, which slightly increases the left ventricular pressure at the end. So point B, left ventricular filling from point A to point B. From point B to point C, isovolumic or isovolumetric contraction, right? Both valves are closed and pressure increases until it opens the aortic valve. Point C to point D, this phase, ejection phase. There is, the volume in the left ventricle decreases, pressure stays or may increase a little bit because of the contraction. And then the last phase, there is no change in volume, but there is rapid change in pressure. So that's the isovolumetric relaxation. So what happens with aortic stenosis? What do you see here on this pressure volume loop? So you learn, yes. So you can see there is an increased pressure in the left ventricle during the ventricular filling. Why there is increased pressure? This is, in diastole. So um, stenotic valve, we'll talk about it here in systole. It's, patients with severe aortic stenosis, they develop what happens with cardiac muscle, left ventricle muscle mass. It increases. They develop diastolic dysfunction because the ventricle is hypertrophied and there is elevated pressures because of the increased stiffness of the left ventricle due to increased afterload because of the aortic stenosis. So there is increased stiffness and increased stiffness in the left ventricle because of the hypertrophy causes uh, elevation of the uh, pressures inside during the diastole. So there is an elevation of the left ventricle and diastolic pressure. So filling is there during diastole, but it's at the elevated pressures during the diastolic phase of the filling. And that's why these patients are also more dependent on the atrial kick, because atrial kick uh, contributes significantly to the diastolic filling in patients with aortic stenosis because of this elevated pressure. Uh, that's why patients who have severe aortic stenosis, if they develop atrial fibrillation, they lose the atrial kick, they can decompensate quickly and causing congestive heart failure. So elevated diastolic pressures. What else? There is decreased preload because of elevated pressures. So there is less volume in the left ventricle. There is decreased volume in the left ventricle. Then, isovolumetric contraction. And then during the systole, what happens during the systole? There is very high afterload, right? Again, we are talking in patients who have severe aortic stenosis. So if there is a small orifice, the heart or the left ventricle is not able to eject the whole amount of blood uh, because of elevated uh, afterload, significant elevated afterload. So there is a high pressure inside the left ventricle, and there is a pressure gradient between the left ventricle and aorta. So you can see that the pressure inside the left ventricle is very high. and there is a decreased stroke volume. This volume is also decreased, right? And then, the isovolumetric relaxation phase, it's it takes a little bit longer, but the pressure drops close to the normal or maybe slightly elevated pressures at the beginning of diastole. So just remember this pressure volume loop for patients with aortic stenosis, because it may be on the step one. I mean, if the change in end diastolic volume here, um, not necessarily, uh, because patients have other comorbidities, uh, but usually we don't assess the severity of aortic stenosis by hemodynamic data in terms of elevation of the end diastolic volume. So you cannot say if the or end diastolic pressure. If the end diastolic pressure is elevated, uh, let's say 14 versus 20, uh, it may signify elevated or more severe diastolic dysfunction, but it is doesn't always correlate with severity of aortic stenosis, because patients can have diastolic dysfunction for other reasons. What is more important in terms of assessment is increased pressure gradient between the left ventricle and aorta. And we assess it by either non-invasive measurement during the echocardiogram, or by catheterization, when we measure by the using the catheter. We measure pressures inside the left ventricle and inside the aorta, and measure the pressure gradient. So typical symptoms are initial symptoms: exertional dyspnea or decreased exercise capacity, exertion chest pain, syncope, and in the late stages, congestive heart failure. Physical findings, you will learn it later. Um, Slow rising and blunted pulse, which is called pulsus parvus and tardus. Um, Reduced systolic pressure and pulse pressure. Again, there is a lower pressure in the aorta in advanced aortic stenosis. And then the ejection murmur, which is the murmur that we hear in, where do we hear the murmur of aortic stenosis? Here. Second right intercostal space. That's where we hear the murmur of aortic stenosis. And there is patients who have severe aortic stenosis. They have soft, or we don't hear the second aortic component of second heart sound, and it's a typical finding when patients lose the second heart sound when we listen at the second right intercostal space. If there is a decreased aortic component of the second heart sound, that signifies really severe aortic stenosis, and that's because the leaflets don't move that well. When the valve closure, which we talked about it, it's the correlation with the second heart sound closure of the aortic valve. So if the valve is like doesn't open and close, you don't hear that heart sound. That you don't hear the second heart sound, because there is no like large movement of the aortic leaflets. So loss of second heart sound is the pathognomic for severe aortic stenosis. Normal aortic valve area is 2 to 4 square centimeters. Mild aortic stenosis is patients who have valve area between 1.2 to 2 square centimeters. Severe stenosis is below 1, when the severity is below 1 square centimeters. And again, non-invasive, most common non-invasive assessment is by echocardiogram. And these are some measurements. Again, we do several measurements during the echocardiogram. Uh, uh, if there is a gradient, P gradient more than 60 millimeters of mercury, or mean gradient more than 40, it signifies severe aortic stenosis. And also we assess the flow across the aortic valve because the more narrow the valve orifice, there is an increased flow, right? When the heart has to eject similar amount of blood, the flow increases. And if the flow velocity, which is normal, less than 2 meters per second, if it's over 4 meters per second, the flow across the valve, which we assess by continuous wave Doppler, it signifies severe aortic stenosis. You don't need to remember these things. This is more for the clinical and especially for cardiology. And this is the aortic valve. You can see it's thickened. This is in systole and doesn't open. There is only small orifice here. This is left ventricular outflow tract, and this is the aorta. And this is a short axis view of the aortic valve. Uh, Again, you can see very calcified and thickened leaflets, and there is a smaller orifice. This is probably patient who has moderate aortic stenosis. This is not severe. Another assessment, flow velocity across the aortic valve. You can see elevated flow uh, up to close to 6 meters per second. So this is really severe aortic stenosis. Uh, Patients usually tolerate aortic stenosis until certain point. There is a latent period which can last several years, 10, 15, 20 years. When they start having symptoms, the survival significantly decreases. So we inform patients about the symptoms of aortic stenosis, and if they start having symptoms, because there is a lot of patients who have severe aortic stenosis, and if they are asymptomatic, usually we monitor them with yearly echocardiogram. But once they start having symptoms, we have to do some intervention. Medical therapy has very limited role. Uh, we usually don't have any good medical therapy that can delay progression of the aortic stenosis. The main thing is basically follow up and information patients about the symptoms. And treatment, surgical replacement using sternotomy uh, with replacement of the valve, either bioprosthetic or mechanical aortic valve. Uh, Indication is patients who develop severe symptoms or patients who go for cardiac surgery who have moderate aortic stenosis, but they go for cardiac surgery for other reasons, like having open heart surgery because of the bypass 3-vessel coronary disease. And then patients who don't have symptoms and have severe aortic stenosis and they start having left ventricular systolic dysfunction, that's also indication for surgery. Balloon valvuloplasty, uh, it's a transcutaneous procedure that we open the valve by inflating large balloon, uh, and it basically separates these calcified leaflets. This is only temporary measure. We don't use this procedure very frequently. Usually it's used only in very sick patients who may need some surgery for other reason, and they wouldn't survive surgery because of severe aortic valve. So this balloon valvuloplasty, usually we don't get a uh, durable effect. Usually after 3 or 4 months, patients can develop recurrent stenosis. So it's only used for bridge to surgery, and again not commonly used. But what is commonly used is the transcutaneous aortic valve replacement now, and more than 50% of patients these days undergo a replacement of the valve using percutaneous technique. Um, this is the transcatheter aortic valve implantation called TAVI or TAVR. Um So the new valve is basically delivered through the groin using the catheter and placed uh, in the place where the original stenotic valve is, and the valve gets inflated. All these metal mesh uh, gets inflated, and then the old valve is squeezed to the wall of the aorta, and then the new valve starts working instead of the old aortic valve. So this is preferred now currently preferred procedure for patients who are uh, over 50 or 55 years old. Usually in younger patients, we talked about it, I think, on Monday or Tuesday. We prefer to implant mechanical aortic valves because they are more durable and patients don't need repeated surgeries as often. So in patients who are over 50 or 55 years old, this is the preferred treatment. Obviously, there has to be suitable anatomy because the aorta has to be large enough. If they don't have enough large enough aorta, uh, because we are putting another valve in the place of the old valve, so we could create already stenosis of the new valve if the aorta is small. So the anatomical, usually patients who go for this procedure, we do CT scan of the whole aorta, measure how much calcification and the size of the aorta, and if these patients are suitable for transcutaneous approach. But it has much less morbidity in terms of hospitalizations. Usually patients go home the next day after the procedure compared to at least 5 days in the hospital for surgical technique, and recovery is much faster. So next is aortic regurgitation. Not as common, but it is also common. We are talking more about a severe aortic regurgitation that requires replacement. It's not as common as aortic stenosis. Uh, Primarily, bicuspid aortic valve is probably the most common uh, regurgitant aortic lesion that leads to surgery. Patients who have bicuspid aortic valve, most of the time they have usually combined stenosis and regurgitation, but initially they usually have isolated aortic regurgitation. And then acquired uh, aortic degeneration, rheumatic heart disease, connective tissue disease, less likely trauma. And endocarditis, yes, it's another common condition that can lead to um, severe aortic regurgitation and needing aortic valve replacement. Usually, patients who have aortic valve endocarditis, they can develop some degree of aortic regurgitation, but patients who have large vegetation, they may develop severe regurgitation causing congestive heart failure, which requires urgent surgery. And aortic regurgitation can be caused also by aortic problem, aortic root dilation. The most common are the congenital abnormalities, Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos syndrome, which is the syndrome with the increased hypermobility, leading to progressive enlargement of the aorta and enlargement of the aortic annulus and subsequently aortic regurgitation. The most common symptoms of severe aortic stenosis is shortness of breath. So dyspnea on exertion and decreased exercise capacity. Um, this is pathophysiology. Aortic regurgitation compared to aortic stenosis leads initially to increased left ventricular volume. So it's a volume problem. Aortic stenosis due to elevated afterload. Its initial problem is the increased left ventricular pressure. So this is more the volume problem. Uh, there is increased stroke volume. Why there is increased stroke volume in patients with aortic stenosis? I mean, sorry, aortic regurgitation. So what happens with aortic regurgitation? There is an increased volume because of the increased flow from the atria as well as from the regurgitant lesion, right? So increased volume in the left ventricle leads to what? Stretch of the myocardial fibers, and Frank Starling law, increased stretch of the fibers leads to increased stroke volume. Late stages, again, left ventricle systolic failure, but it's really in the late stages of severe aortic regurgitation. Patient can tolerate aortic regurgitation well until the late stages. There is also decreased diastolic blood pressure, and it's one of the features of aortic regurgitation is elevated pulse pressure. So patients can come with blood pressure like 140 over 50 if they are not on any vasodilators or medications and they have diastolic murmur. This is usually um, signifies significant aortic regurgitation. Uh, these are, so I mentioned wide pulse pressure. These are the typical older um, signs, physical findings in patients with aortic regurgitation. What is the Demoset sign, Corrigan's? Have you heard about these physical findings? All right, so let's do it. It's more historical. We almost never see. You can see it on YouTube. We almost never see these advanced patients who have advanced, aortic regurgitation. What is the Demoset sign? Bobbing of the head, right? With aortic. You can look at the YouTube. You can see some patients who really have significant aortic untreated regurgitation. So the movement of the head, during the cardiac cycle, so bobbing of the head with each heartbeat. What is the Corrigan's pulse? So prominent carotid pulsation, again, because of the increased stroke volume. Quincus pulsation, it's a capillary. It's a pulsation in the capillaries. You have to have, you have to have a slit lamp, and you can look at the capillaries in the nails, and you can see the pulsation again because of increased peripheral vasodilation and increased stroke volume. What is the Muller sign? Pulsation of the uvula. Same thing for the same reason. And what is the Austin Flint murmur? Why? Yes. So why is what is the pathophysiology causing the Austin Flint murmur? It happens in patients who have eccentric jet, regurgitant jet that is directed towards the anterior mitral valve leaflet and causing basically functional mitral stenosis. So it's a diastolic rumbling uh, and causing basically functional mitral stenosis in diastole. So Austin Flint murmur, it's murmur of functional mitral stenosis due to decreased leaflet opening, anterior mitral valve leaflet because of regurgitant aortic jet. But the pathognomic, and you should be able to hear it, is the early blowing. Early, it starts right at the beginning of a diastole, early blowing diastolic murmur, which we placed here at the left mid parasternal area. All right, I don't think we need to go through the echocardiographic findings. And again, another pressure volume loop, patients with aortic stenosis. So what do you see here? Increased volume, right? You have volume increased from the from the aorta, back backward volume, and increased flow, combined flow from the left atrium and from the aorta. What else do you see here? So increased stroke volume, increased left ventricle and diastolic volume, Frank-Starling law again, and there is no or only mildly depicted. There is no significant isovolumetric contraction because there is still increased flow from the dysfunctional aortic valve and increased stroke volume, and then there is also lack of isovolumic or isovolumetric relaxation phase. And again, because there is a backward flow, so there is a change in the volume in the left ventricle in the during the initial stage of ventricular relaxation. So remember this big loop uh, of the aortic regurgitation. This is a still picture. If we have time at the end, I have some pictures of the echocardiographic images of the aortic regurgitation. So this is the left atrium, right? Mitral valve, left ventricle outflow tract, and here is the aortic valve. You know, this backward, this mosaic pattern is the backward flow of the aortic regurgitation back to the left ventricle. And if this flow is directed towards the mitral valve anterior leaflet, it doesn't allow the opening of the leaflet in diastole, causing the uh, functional mitral stenosis and Austin Flynn murmur that you can hear at the apex. Management, medical treatment using diuretics and vasodilators in patients with um, elevated pressures. Surgery is the main therapy for aortic regurgitation, uh, aortic valve replacement. Usually, we don't have right now currently available percutaneous treatment for aortic regurgitation. So surgery is the mainstay of therapy. Uh, Indication, again, patients who have symptoms with normal left ventricular function, patients who have left ventricular systolic dysfunction or dilation. So this is the volume problem. Like I mentioned, patients usually tolerate uh, small or slow enlargement of the left ventricle uh, because they increase the stroke volume. Uh, that's why they don't have really symptoms unless or until the left ventricle is significantly enlarged. And usually, if the left ventricle and systolic diameter is more than 55 millimeters, usually normal left ventricle diameter in systole is less than 35 millimeters. So if the left ventricular dimension in systole is more than 55 millimeters, it's indication for surgery in asymptomatic patient. And obviously, patients who have a problem with the aorta, they need both the aortic root replacement and aortic valve replacement. Sometimes there are surgeries that are done in patients who have intact aortic valve. If it's only pure problem with the dilation of the aortic root, there is a valve sparing surgery. So the surgeon tries to preserve the original native aortic valve. Next lesion is mitral lesion, mitral stenosis. Most common cause, rheumatic valvular disease, less likely congenital disease, and less likely autoimmune disease due to lupus or rheumatoid arthritis causes thickening of the mitral valve, causing significant stenosis. We almost never see it, but most common cause is rheumatic valvular heart disease. There are other causes like left atrial myxoma. You know what a left atrial myxoma is? It's a benign tumor, which is most commonly located in the left atrium. When this tumor, which can grow slowly, when it's large enough, it can obstruct the orifice of the mitral valve, causing mitral stenosis. Infective endocarditis with large vegetation, it's another cause which sometimes requires surgery. And cor atriatum, there is an extra membrane in the left atrium that causes basically obstruction, membrane that causes obstruction of the mitral valve, causing mitral stenosis. Again, this is very rare condition. So in rheumatic heart disease, especially in the developing countries, it's common cause causing fusion of the valve leaflets and commissures as well as chordae. So there is a fusion, but there can be also a lot of calcification. Uh, You may remember, you may get this Luttenbacher syndrome, which is a rheumatic mitral stenosis associated with atrial septal defect. It's can be a question on this on the boards or on the step 1 or step 2. Normal valve area of mitral valve is larger than the aortic valve. It's 4 to 6 square centimeters. When patients have severe mitral stenosis, uh, it's if they have valve area below 1 square centimeter. And again, there are different calculations. We use it most commonly echocardiogram, either transthoracic or transesophageal from the esophagus and from the stomach. And usually symptoms are decreased exercise capacity, shortness of breath because of decreased filling of the left ventricle. A lot of times patients can live with mitral stenosis for many years before they start having symptoms. Uh, we monitor them with echocardiogram every year or two. We also monitor for pulmonary hypertension because patients have problem with elevated left atrial pressure when there is a severe mitral stenosis, which can lead to elevation of the pulmonary artery pressures, causing pulmonary hypertension. So when patients develop significant pulmonary hypertension, it's one of the indication for surgery, even in asymptomatic patients. And a lot of times, because of increased enlargement of the left atrium, there is a significant risk of atrial fibrillation. And these patients also have high risk of cardiac embolization, higher risk than patients who develop atrial fibrillation for other reasons. So patients with mitral stenosis and atrial fibrillation, they are at high risk for cardioembolism, and they all need to be anticoagulated. Uh, Physical findings. There is a loud first heart sound due to thickened mitral valve. And then you can hear opening snap in diastole, again, because the valve is thickened and dysfunctional, followed by the rumbling mid-diastolic murmur, uh, which you can hear in the apical area. And in patients who have sinus rhythm, there can be um, increased accentuation or called presystolic accentuation of the murmur in sinus rhythm because of the atrial kick. Pressure volume loop, mitral stenosis. What do we see here? What's the problem in patients with mitral stenosis in terms of left ventricular filling? There is a reduced what? Reduced preload, right? Because of there is a reduced filling. So what happens? Reduced preload, reduced stroke volume. Yes. So there is a higher pressure, increased pressure difference between the left atrium and left ventricle. Um, so decreased preload leading to decreased stroke volume because of the Frank-Starling mechanism, reduced ventricular filling, and subsequently reduced aortic pressure. Mhm. Isovolumetric here. This is the isovolumetric contraction. Ejection here. Yeah, there is a decreased, there is a decreased pressure, and the ejection is also decreased because there is a decreased volume. So the stroke volume is decreased in patients with aortic stenosis. The in diastole, the pressure does not increase because of the decreased filling. So the end diastolic pressure is the same or maybe actually lower. So this is the pressure volume loop patients with mitral stenosis. Echocardiographic assessment. Um, this is how the valve look like in diastole. This leaflet should be normally open because of the elevated pressure between the left atrium and left ventricle, but you can see the leaflet is closed. This is called like hockey stick uh, pathognomic for mitral rheumatic mitral stenosis. Hockey stick appearance of the left mitral valve anterior leaflet. These are the other. This is the left atrial myxoma. You can see this large mass, echogenic, bright echogenic mass that is basically taking the whole left atrial uh, cavity and obstructing the flow, diastolic flow through the mitral valve to the left ventricle. This is relative urgency. If patients come late like this, they need urgent surgery because of first possible cardioembolization, but also severe functional mitral stenosis. So they need the excision of this big, large atrial myxoma tumor. Medical treatment, uh, not too much treatment in terms of slowing progression of mitral stenosis, avoidance of severe physical activity in patients who have severe stenosis. But usually the main treatment is if patients develop atrial fibrillation, anticoagulation. We mentioned higher risk of cardioembolic events, and then follow up for progression by echocardiogram, either assessment of the valve area or we are monitoring for development of pulmonary hypertension. Uh, we don't need to go through this criteria for mitral stenosis. That's more for the cardiology boards than step 1 or step 2. Treatment, patients who have rheumatic mitral stenosis, and they don't have significant calcified mitral valve or subvalvular apparatus, they are suitable for balloon valvuloplasty. So compared to aortic stenosis, the balloon valvuloplasty is a durable therapy. And this you can see the balloon that is inserted and inflated, which basically separates the anterior and posterior mitral valve leaflet, and it 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 it's a therapy that is uh, suitable for patients who don't have a lot of calcification, because patients who have very calcified valves or calcified subvalvular apparatus, they can develop complications, and specifically uh, either um not optimal not optimal treatment in terms of reducing of the gradients, but also they can develop mitral regurgitation, which can lead to need for the surgery. So, but uh, balloon valvuloplasty is a good treatment, again, patients who don't have very calcified valve. And then mitral valve replacement uh, is the next, is the main therapy, main surgical therapy, using either mechanical or bioprosthetic mitral valve. The next lesion is mitral regurgitation. Uh, it can be chronic mitral regurgitation, acute mitral regurgitation, or mitral valve prolapse leading to mitral regurgitation. Um, Mitral valve is more complex valve than the aortic valve, and regurgitation can affect several parts of the valve, causing to regurgitation. So it can be affected by the leaflets. Problem with the mitral valve leaflets can cause mitral regurgitation, either due to rheumatic heart disease, endocarditis, myxomatous degeneration, especially in patients with mitral valve prolapse. But the problem can be also in the chordae. Partial or complete rupture of the chordae can lead to dysfunction of the leaflets and regurgitation, or papillary muscles, especially in patients who have myocardial ischemia, patients who have partial or complete papillary muscle rupture. The first presentation can be acute severe mitral regurgitation. And then the mitral annulus, if there is a dilation of the mitral annulus for several reasons, especially in patients who have severe dilated or ischemic cardiomyopathy, they can develop functional mitral regurgitation because of annular dilation. Usually, the main symptom is shortness of breath and fatigue. Physical findings, there is a holosystolic murmur, uh, which you can best hear in the apical area, which is the fifth um, intercostal space in the midclavicular line. Um, so it's holosystolic murmur. It starts right in the beginning of systole because there is a significant um, uh, leakage or regurgitation which starts right in the beginning of systole, and it lasts throughout the whole systole. The murmur can radiate to, and it depends on the location and depends on the which leaflet is affected, but it can radiate to the axilla, or sometimes it can radiate towards the aortic valve if the regurgitant jet is directed anteriorly towards the valve. Uh, and if the jet is central, so the regurgitation jet is more going posteriorly, you can hear the jet in the axillary or in the axilla. If there is problem with the posterior leaflet of the mitral valve, the jet is directed towards the aorta, and you can hear it more anteriorly. So the last pressure volume loop I have for you today is the mitral regurgitation. So what happens here with the mitral regurgitation? Increasing ventricular filling, yes, because there is an increased flow from the left atrium, right? So, and again, same thing, right? Increased ventricular filling, increased stroke volume because of the uh, Frank Starling mechanism. And you can see there is uh, no isovolumetric contraction or relaxation because of continuous change in the volume because of dysfunction mitral valve. You mean here? Isovolumetric contraction? Yeah, so there is no isovolumetric contraction because when the ventricle starts contracting, uh, there is, because of the dysfunctional mitral valve, there is already uh, change in the volume because of the regurgitation. So there is no isovolumetric contraction phase because the valve is already dysfunctional, and it's not. I mean, it's closed, but it's leaky. It's already in the beginning of systole. It starts. The regurgitation starts right away as soon as the left ventricular uh, pressure starts increasing. So there is no isovolumetric contraction, and you can see that there is already decreasing volume during the what's supposed to be the isovolumetric contraction because of regurgitation that starts right away when the pressure inside the left ventricle increases. And there is a increased stroke volume because of the increased yes, that's here, right? And diastolic left ventricle and diastolic volume. So there is increased left ventricular and diastolic volume, no isovolumetric contraction or isovolumetric relaxation. And again, because there is a continuous leakage through the mitral valve because of the regurgitation. Um, Same thing in patients with mitral regurgitation. We don't have specific treatment to delay progression. Uh, the main treatment is patients who have hypertension uh, using vasodilator therapy to increase the um, uh, basically decrease the afterload, increase the flow through the aortic valve, and decreasing the backward flow through the dysfunctional mitral valve. So vasodilator therapy and patients who develop atrial fibrillation, use of beta blockers, and obviously patients who are congested, if they develop symptoms of heart failure, they need diuretics. Surgical treatment, patients who develop symptoms, patients with mitral regurgitation who develop symptoms, or uh, patients who have dilated left ventricle. We measure again by echocardiogram left ventricle and systolic diameter. Uh, in the aortic regurgitation, the number was 55. In the mitral regurgitation, the number is 45 millimeters. You don't have to remember it. And treatment is either mitral valve repair or replacement. Usually, if patients have suitable anatomy and there is a good surgeon, the preferable treatment is repair of the valve. Usually, the valve is repairable if patients have mitral valve prolapse due to myxomatous degeneration. So mitral valve repair is preferable because it preserves the natural leaflets, natural valve, compared to the replacement, which can sometimes lead to post-operative, either early or late post-operative left ventricular dysfunction. And also, patients who are young, uh, they don't if they require replacement, usually it's mechanical valve. They require anticoagulation. Young patients who have mitral valve prolapse and they require surgery, mitral valve repair uh, is preferable. They usually don't need anticoagulation. All patients, and I didn't mention all patients who have uh, valve surgery with replacement or repair, they need antibiotic prophylaxis in the future for to decrease the risk of endocarditis. So antibiotic prophylaxis is important in patients who have any type of valve surgery. Acute mitral regurgitation usually most commonly occurs either in patients who have infective endocarditis and come in as a late presentation, or uh, ischemia and either partial or complete rupture of the papillary muscle. Usually these patients are sick. They come uh, in florid pulmonary edema, heart failure. They cannot breathe. They are sitting. They are very short of breath, and you may not hear the murmur. You may not hear the murmur of the um, of the mitral regurgitation, or the murmur can be just very soft, even in patients who have severe mitral regurgitation, because there is a significantly elevated pressure, acutely elevated pressure in the left atrium, and left atrium is not dilated, so there is not that much that high pressure difference between the left ventricle and left atrium. So even if you don't hear the murmur, patients who come for unclear reason, acute pulmonary edema, unclear reason, and you don't hear the murmur, doesn't mean that they may not have severe mitral regurgitation. Um, I'm gonna skip these. So acute mitral regurgitation, the transient therapy is vasodilation, but usually these patients come with cardiogenic shock. Uh, Sometimes they require intra-aortic balloon pump. We can skip, the treatment, but the mainstay is to go to surgery as soon as we find the cause, and they need basically. Usually they require aortic valve, mitral valve replacement. So acute mitral regurgitation is a cardiac emergency. It's not easy to detect, and you should always think about it in patients who come with unexplained pulmonary edema, although they may not have significant murmur. We talked about the mitral valve prolapse a little bit. I'm gonna skip it. This is the echo finding of mitral valve prolapse. The mitral valve leaflet is basically in systole, uh, goes backward towards the left atrium, causing dysfunction and the regurgitation through the dysfunctional mitral valve orifice. Uh, Mitral valve clip is a new technique which is usually reserved for. Have you heard about mitral valve clip reserved for the elderly patients who have a lot of comorbidities and they are not suitable for surgery, for mitral valve surgery? So mitral valve clip is a procedure that, again, from the femoral artery, we have little clip that um, sorry, that's from the femoral vein. It's done by using the transeptal catheterization, but the clip basically is a little plastic piece that clips and two leaflets of the mitral valve together. So if the patients have dysfunction mitral valve, they clip and uh, clip the leaflets together, and you basically cause two orifices. You cause little mitral stenosis, but you can significantly reduce by this clip mitral regurgitation. Sometimes patients need one or two clips to reduce the regurgitation. Uh, but again, it avoids or doesn't necessitate surgery. Still, now it's reserved for more elderly patients and patients who have comorbidities who are not suitable for mitral valve surgery. But it's new procedure that is used more frequently. Even at Yale, we use it more frequently in patients who have significant mitral regurgitation and if they don't want to have surgery. Uh, Tricuspid. So the right-sided lesions are uh, not as frequent, and patients, usually I never seen or maybe one patient I saw with tricuspid stenosis. Usually these patients have rheumatic heart disease and they have other valve diseases. So, but usually we don't see that frequently. Uh, Tricuspid regurgitation is more common. Patients are able to tolerate significant tricuspid regurgitation. Uh, Usually, we don't send patients to surgery for isolated tricuspid regurgitation unless they have really severe symptoms, and the symptoms are uh, um, right-sided, basically increased vascular congestion, hepatomegaly, ascites, or leg edema. Pulmonic stenosis, the most common is congenital malformation. Usually, patients don't develop if they have normal pulmonic valve. If they don't have congenital abnormality. Usually, patients don't develop pulmonic stenosis due to degeneration of pulmonic valve. Uh, One syndrome is a carcinoid syndrome. I didn't mention it in patients who have tricuspid valve disease. Uh, Carcinoid disease can cause restriction of the leaflets, thickening and restriction of the leaflets, more commonly in tricuspid valve. Sometimes we see it in pulmonic valve, and it can cause stenosis of the tricuspid or pulmonic valve, sometimes requiring surgery. So carcinoid tumor can cause stenosis of the tricuspid or pulmonic valve. Pulmonic regurgitation, again, less common. Um, a lot of patients can have mild or moderate pulmonic regurgitation. Most of the patients don't develop progression. Most of the patients do not need treatment for pulmonic regurgitation. And I think that's it. It's 9:08. Do you have any questions? Patent ductus arteriosus. Say what? It's not a valvular disease. So what does the ductus arteriosus? What does it cause? The physical finding. So what happens with ductus arteriosus? Why do we have it? It's important in uterus, right? Hmm? If patients have the patent after they are born, because usually it closes when you are born. So when it stays open, what happens? What did you say again? So, but what happens when you are born with patent ductus? Abnormal connection between the uh, pulmonary pulmonary artery and aorta, right? So the physical finding is what? So it's continuous murmur. Where do you hear it the best? On the left side, right? Left left subclavicular area at the level where we hear the pulmonic valve. Yes. And because of the hemodynamic findings, basically, if it doesn't close by itself, uh, it requires surgical closure of the patent ductus. I had like 4 slides uh, for you to show you different lesions. We'll just do it quickly. It's just a couple more minutes. Huh? Yes. These are the real patients that I took a video. I mean, I saved on the video clips. So what is it? It's regurgitation, right? You see the backflow. Is it the mitral or tricuspid? It's a mitral. This is a transesophageal echocardiogram. You see the dilated left atrium. So is the opposite compared to transthoracic when the probe is in the stomach. Uh, the next to the stomach or esophagus is the left atrium. So the probe is here. So the closest to the probe is left atrium. So this is the large left atrium. This is the mitral valve, and here is the opposite compared to transthoracic. This is the aortic valve. This is the left ventricular outflow tract and aorta. So you can see this backward flow. It's probably moderate mitral regurgitation. And this is the central jet. This is the central jet. So you can hear the murmur where the murmur radiates. When you hear the hollow systolic murmur at the apex, radiates where? To the axilla, right? But sometimes, like I said, the jet can be directed towards. This is the posterior leaflet. If there is dysfunction of the posterior leaflet, the jet can be directed anteriorly towards the aortic valve. So you can hear that the murmur can radiate towards the aortic valve. So this is the central jet. Next, what is this? Stenosis on the left. Both are stenosis. What stenosis is this? This is a two-dimensional view of what? What valve? aortic valve. Mitral valve is here. This is the aortic valve. This is the aorta, and this is the aortic valve. And this is a short axis view of the aortic valve. You can see the thickened valve that doesn't open. You can see, the one leaflet, two, and then there is a third one here. Uh, but the leaflet is thickened and doesn't open as well. So aortic stenosis, uh, thickened valve. This is the same patient, yes. Two different views. What is this one here? What do you see is going on here? It's different patient, but it's the same view like the previous patient. So it's aortic valve, right? And it's aortic regurgitation. Again, you see the back flow here, this mosaic flow that goes back towards the left ventricle. But what is the problem here? Vitality patient came with fevers, elevated white count, and positive blood cultures. It's a large vegetation. You see this large vegetation. This is the real patient. Large vegetation on the aortic valve, causing dysfunction and regurgitation. And then this is not easy because we haven't discussed this view, but this is a patient who has pulmonic stenosis. Again, you can see this mosaic pattern. It should be, away from the probe. The color should be blue, but you can see there is a uh, there is an increased flow through this pulmonic. This is the pulmonic valve, and um, there is an elevated velocity, and due to basically narrow orifice of the pulmonic valve. So this is a pulmonic stenosis. I wouldn't expect you to know this. And I think that's it. These are just few real echo loops that I put in together yesterday. All right, valves. That's it. We didn't talk about the combined. It's not always these simple things. Aortic stenosis, aortic regurgitation. Sometimes there can be two valves involved, and then you try to decide what is the best for the patient, what you should do when you send them for surgery. It's not easy. It requires clinical assessment, discussing with patients, but it's fun to take care of patients with valvular heart disease. All right. Sorry, 17 minutes late. You're welcome.